everyone. Welcome to Health for the World International Grand Rounds. We are really honored to have our Grand Round speaker today, Dr. Lucy Muinov. Uh, she's Associate Professor of Radiology at University of Nebraska and an expert in contrast media and contrast reactions. We are really honored to have her today. Dr. Muinov did her medical school at University of Nebraska and also did her internship, residency, and fellowship in abdominal imaging in the Department of Radiology there. She practices abdominal imaging and breast imaging, and we are really delighted to have her present today on contrast media and contrast reactions, which is such an important topic. And given her expertise, we would love to learn from her. Thank you so much, Lucy, for doing this for Health for the World. I really appreciate this, and we would, you can start whenever you're ready.
Sure, thank you for having me. Thank you for that kind introduction as well. So, yes, I'm Lucy Muinov from Omaha, Nebraska. Here, I do body and breast imaging, and contrast media and contrast reaction is a special interest of mine. Early on in my career, I was involved in several contrast reactions, some of which luckily went well, while others we felt like we were not as prepared as we could have been, which made me want to learn more and prepare myself better for future contrast reactions. I have no disclosures. So I grew up in Belarus. I know this is a Health for the World lecture, so I thought I would include a small map. So I grew up here in southern Belarus. I was 16 years old when my parents immigrated to the United States. And we came straight to Omaha, Nebraska, right here in the center of the United States. And that's where I've been ever since. I did my training here, my fellowship in body and breast imaging, and that's what I do now. And this is what my house looks like yesterday. We have lots of snow and we have very cold, frigid temperatures here in Omaha. So those of you who have been doing radiology might know the feeling where you answer the phone call and you get that dreaded phone call from CT technologist or from a nurse, and the person on the other line says, doctor, I need you to come to CT right away. My patient is not doing well after CT scan. And the first thing that comes to your mind, what is my own pulse? I understand that they're probably asking me to go and attend to a contrast reaction, and I need to act quickly and remember my epidoses as you're running to the CT scanner. So as we're going there, the first thing that I always teach residents is that you literally have to know where you're going. First of all, who called you? Which room are you going to? If there's a hospital with several different scanners or different nursing station, we must know where to go. Where is our patient located? We had cases in the past where the resident went to a whole other part of the hospital, to a totally different room, and then it took them a while to find the correct room. So where am I going? Where's the patient located? And as we're running towards that room, there are several things that we might be thinking in our minds, right? We're going over the epinephrine or adrenaline doses. Was it 1 to 1,000 intramuscular dose? Was it 1 to 10,000 IV? Do I give 0.3? Do I give 0.1 milliliter? Is it in milligrams? Is it in milliliters? So our own anxiety perhaps might hinder our knowledge of the doses. We might be thinking about chest compressions and the cardiopulmonary resuscitation. And first of all, what's my own pulse, right? We need to be able to control our own anxiety dealing with a stressful situation like this. So luckily, in our country, in the United States, the American College of Radiology produces a very detailed document. It's a free document. It's available online. It's in PDF format. It's easily accessible to anybody with access to internet. We use Google commonly, and I use this document nearly every day, sometimes several times a day. I teach my residents to use it as a reference. You just type in Google ACR manual, and this entire document pops in, and here's the website and the link to this document. Now, I understand and respect that other countries, other radiological societies have their own guidelines, but this is what I follow as an American radiologist, and this is what I will mainly refer to in this talk today. So there's a group of physicians who are very thorough, very detailed. I appreciate all the work that they do, staying current. They produce a new version of this document nearly every year. The newest version, as I found out 2 days ago, just came out in January of this year, January 2021. There was an update on the version from a year ago, from 2020. So I tried to look through and update my talk as needed. So today we will go over iodinated and gadolinium-based contrast agents, patient selection, pre-medication protocol, contrast reactions and management, contrast extravasation, post-contrast acute kidney injury and contrast-induced nephropathy, and we will briefly touch base on MRI gadolinium-based agents and nephrogenic systemic fibrosis. So contrast agents in radiology, we commonly use various types of contrast agents. For CT, we use iodinated contrast agents. For MRI, we use gadolinium-based agents. They help us see things better. They make our diagnoses more accurate, especially in body imaging, and that's what I do. We are a group of radiologists who give IV contrast more commonly than any other section, right? We use contrast more than neuroradiologists or musculoskeletal radiologists. Most of our studies, CTs and MRI, will require IV contrast. When we give IV contrast, it is us as radiologists, as physicians, prescribing a medication to our patient. When I was going into radiology, I thought that I would never write a prescription ever again in my life for a medication. However, each patient that I read, it is my name as a radiologist and as a physician prescribing a medication to my patient, and I'm responsible for that administration. If I'm giving gadolinium to my patient, then I need to make sure that it is safe and it's the correct dose. Okay. In the United States, we perform 70 to 80 million CT scans annually. So that's a lot of boluses of iodinated contrast, even though adverse reactions or side effects are rare, luckily, but from sheer volume of the scanning that we do, some patients will have contrast reactions, and we all must know how to attend to them and help our patients. So as we mentioned, for CT, we use iodinated contrast. For MRI, we use gadolinium-based agents. So why is it important? Well, here's a non-contrast CT, and on the right is a contrast-enhanced CT, and oral contrast here in the stomach. We see IV contrast in the kidneys. We see aorta and vessels opacified. So if we're looking for cancer, for staging, for metastatic disease, for vascular abnormality, for inflammatory processes, we must have that dye, or we might miss a certain amount of information. Okay, that's why it's important to prescribe that medication, that iodinated contrast, to majority of our patients. So there are different types how we classify iodinated contrast. There's ionic and non-ionic contrasts. There are different osmolarities. Some of them are high osmolar, low osmolar, and isoosmolar. Majority of the modern agents, at least that we use in our country, are non-ionic and low osmolar agents. And those are the agents that are safer than the older agents. So some patients will say, well, I didn't do well with, I had a CAT scan 15 years ago, 20 years ago, and I remember being sick from it. Well, things have changed. Luckily, our agents now are safer and patients don't have as many physiologic or allergic type reactions to these newer agents. So here's a chart, again, that describes the high osmolar, low osmolar, and isoosmolar agents. We can look at the different osmolality of these agents. So these high osmolar agents are not given intravenously anymore. They're usually used for gastrointestinal and GU or studies. The low osmolar and isoosmolar agents are used intravenously or intraosseous injection. Okay, So there are different types of low osmolar agents. The one that I'm used to, iopamidol, is what we use in our institution. And there's a single isosmolar agent, which is a Visipig, that's the brand name. So in the manual, there are lots of charts. The ACR manual is now very organized, and I like that it classifies lots of contrasts and contrast reactions, and they're very systematic and organized into different charts. And this is just one of the charts that lists different brand names and the generic names, the osmolality. The one that we use is Isoview. The generic name is iopamidol, which is the low osmolar agent. So you can see the osmolality is 796, which is still not close to the blood osmolality of about 300. So it's still higher than the blood osmolality, but it's better than some of the older high osmolar agents. It's tolerated better. So we don't have to give contrast to everybody. We must select our patients. The way we do it in our practice, our residents usually protocol the studies for the following day, the day before. So let's say at 4 p.m. today, our body residents or fellows will protocol each patient for the following day or the following week. They will look through each indication and to see what the doctor ordered, and they will decide whether or not that is the right study. Does the patient need contrast, or do we not need contrast? If it's a kidney stone study, then we don't have to expose them to that iodine potentially. If we're not clear, we will call the ordering physician and discuss the indication and the appropriateness of the exam with them. We must balance the likelihood of an adverse event with the benefit of the exam. We need to realize that having that contrast in most cases, for body cases, will help us make a better diagnosis. And we need to be prepared to treat a reaction should one occur. So there are certain risk factors for adverse reactions, and adverse reactions covers a broad category of allergic type reactions and physiologic reactions, also renal related adverse effects. So some of the risk factors are history of prior allergic-like reaction, which might increase 5-fold the patient to have another allergic type reaction. Having any allergy, so that includes other medications or food allergies, having that atopy increases patients' risk 2 to 3 folds of having reaction to the IV contrast. Having asthma, renal insufficiency, we check on their cardiac status, anxiety. Those are all the things that we may need to know to make that educated decision to give IV contrast. Contrary to a common belief, shellfish and dairy allergy are not risk factors for administration of iodinated contrast. So when we select the patient, decide whether or not they need IV contrast, if they have history of prior reaction, we may need to consider alternate exam. So instead of exposing them potentially to another iodinated contrast, can we do an ultrasound exam? Can we do an MRI? It may not be on the same day because we have to reschedule them for MRI, but sometimes we have to switch our studies, or maybe we can do a non-contrast exam and get enough information. If they have history of prior reaction, we may need to pre-medicate them. If they have history of severe allergic-like reaction, we will try to not give them contrast anymore. There are certain scenarios where we have to give contrast. For example, if it's a trauma patient and the surgeon is worried about aortic laceration and they're bleeding, and we absolutely must give them contrast, and we have to pick our battle. Do we give contrast and expose them to potential allergic reaction? Or do we not give contrast and skin without, and we may not know that they're bleeding or that there's liver laceration? So then it's a conversation with the clinical team deciding, where we're going to pick our battles. If we're going to scan a patient with IV contrast with known prior severe allergic-like reaction, I personally request that the clinical team or a member of the clinical team, a resident, fellow, and nurse, comes with the patient to the CT room. I will tell on the phone, to that ER physician, I understand that we must give contrast. I understand the situation. We're looking for pulmonary embolus, saddle embolus, aortic dissection, ruptured aneurysm, trauma patient. We must give IV contrast, but I also understand that the patient had prior severe allergic-like reaction, and I'm worried that we might, put them again in that situation. So I will say, I need one of you clinical doctors to come with the patient and be there by the machine in the CT room. And if the patient is going to go into the anaphylactoid reaction, then we will all be better suited to help that patient together rather than just the technologist and the radiologist in the room. If they have history of mild to moderate reaction, then the patient may need to be premedicated with a steroid and Benadryl prep. That would be preferred. Now, having that prep does not eliminate future contrast reactions, even though the patient took those steroids and Benadryl as they were instructed the day prior, they can still have 2% chance of having breakthrough reactions. So this is the American College of Radiology pre-medication protocol. It's a combination of a steroid and an antihistamine. What we use in our country is prednisone. It will usually be given at 50 milligrams orally at 13, 7, and 1 hour before the exam, plus diphenhydramine, the generic name or brand name Benadryl. And we can give it IV, intramuscular, or oral, 50 milligrams, 1 hour before the exam. So typical outpatient will have 50 milligrams of oral prednisone the day before. They will have 3 doses and 50 milligrams of oral Benadryl 1 hour before the exam. This is what we advise to clinicians when they call us on the phone asking how to premedicate patients. There's another way of premedication with methylprednisolone as a single agent at 32 milligrams at 12 and 2 hours. And Benadryl can also be added, but it's not necessary to add if we use methylprednisolone. Now, I value and respect other societies' guidelines. Unfortunately, I'm not familiar in detail with all the other societies' guidelines. With the European Society of Urogenital Radiology, again, accessed by me online, what I found is the pre-medication protocol includes prednisolone 30 milligrams orally at 12 and 2 hours before contrast medium. It's important for you all to know your own area's guidelines. So whichever society you usually follow and the guidelines, then you may need to look it up and know those guidelines. There's also an emergency pre-medication. So what if it's an inpatient or an emergency room patient and we don't have 13 hours to pre-medicate them? Then there are different ways. Usually it's a combination of IV steroids. Again, they're listed here. Again, I don't remember all these doses. If somebody calls and say, how do I pre-medicate my ER patient? I will have to open up again, online on Google, the ACR manual or our own department policy and look up these doses so I can tell the physician, you can use methylprednisolone, you can use dexamethasone plus Benadryl. The goal is to wait as long as possible before the exam. So literature says that these IV steroids have not been shown to be effective when administered less than 4 to 5 hours prior to contrast injection. So it's a conversation usually with an ER physician. I will say, yes, I'm recommending IV steroid prep for your patient. However, how much time do we have before we scan? Ideally, we would wait 4 hours. But I've never heard of an ER physician allowing us to wait 4 hours prior to scan. Usually they say, I must know now whether or not this patient has a pulmonary embolus or aortic dissection or trauma patient. So usually they will wait maybe for 20, 30 minutes at the most, depending on the case. But ideally, we would wait 4 to 5 hours for that IV pre-medication. So now we will talk about actual contrast reaction recognition and treatment. Again, most of my references come from the American College of Radiology manual on contrast media. So on their website now, there's a reminder card. And this card is very helpful. So this is just a picture of the card. It's a summary of what we're about to look at. As you can see, it has some information about contrast extravasation, pre-medication protocol, and what to do when these contrast reactions happen. You can print this card. You can make a copy on your phone. You can put it in your pocket. My department printed and laminated. So I can show you the card. I carry this card in my pocket with this information so that I don't forget. Sometimes each resident, each staff member has a card like this. We have them laying on each table where we dictate our studies. So in case of an emergency, perhaps a resident can grab a card like this, and that will be a reminder for them what to do in that stressful situation. So this is an adult. We also have a number here of our emergency response team in the hospital written in this box. So again, if we need help, and in the case of severe reaction, we do need help. We need a resuscitation team to come and help us and do chest compression, sometimes intubate the patient with severe reaction. So we need to call that number and know that number by heart, ideally to get help in radiology. This is the back of the card, and there's also a pediatric card that looks like this with different doses based on child's weight. So luckily, these adverse reactions or contrast reactions, some people call them events, other people call them reactions. Luckily, they're rare, but from pure volume of studies that we do end up seeing them. I would say on the average, in the body reading room, we get at least maybe 1 or 2 phone calls a week to look at a mild reaction, such as hives, maybe some itching, some sneezing, watery eyes. It's rare, luckily for all of us, to get a phone call with that severe allergic-like reaction. But in my own opinion or experience, I feel like I do maybe at least once a year that I have to administer epinephrine to somebody with severe allergic-like reactions. Okay, and I've done it before. I've done chest compressions. I've been involved in several situations like this. So with iodinated contrast, the quoted number of contrast reactions is about 0.6%, and out of those, 0.04% are severe. For gadolinium-based, 0.01 to 0.2%, and severe reactions are extremely rare. Commonly quoted number of deaths from contrast reactions is 1 in 170,000 injections. Okay. And these reactions can range from physiologic and minor, such as nausea, to mild allergic-like, such as hives, to severe and life-threatening anaphylactoid types, such as shock and death. So physiologic reactions are predictable. They're dose and concentration dependent. So we almost expect that the patient might have them after giving that bolus of IV contrast. They can affect cardiovascular, neurovascular, and renal systems and clotting cascade. Versus allergic-like reactions, they're less predictable. They do not depend on dose or concentration. Sometimes the terms that we apply to them are anaphylactoid or idiosyncratic, meaning that they're not true anaphylactic reaction, such as, let's say, a bee sting patient would have anaphylactic reaction, but they act similarly. Clinically, they look just the same as if a person is having a true anaphylactic reaction. That's why the term is different, anaphylactoid, but they don't have the same physiologic mechanism as true anaphylactic cascade. So as far as timing of the reaction, most of them will occur in the first 5 to 20 minutes after the injection. Usually they happen nearly right away, meaning the exam is done, the patient is still on the CT table, the technologist goes in to help the patient get up, and they're not getting up. They're pale or they're clutching their throat because they have laryngeal edema. They're not able to speak. And that's when the technologist recognizes that they're having severe reaction or whatever reactions they happen. Versus hives, in my opinion and experience, the milder reactions, they might be a little bit more later. Severe reactions happen quicker, usually, right after the injection. So we can also have delayed reactions, delayed as long as 1 week. So when the patient leaves the CT room after having IV contrast, we usually instruct them, the technologist will say, you did well today, you look good. However, we just need to watch you, kind of pay attention to your health for about a week, because there's such a thing as delayed contrast reaction. Most of those are cutaneous and mild, such as urticaria or itching, some redness of the skin, rashes, pustules, pruritus, but there are also non-cutaneous delayed reactions, such as nausea and vomiting and fever and drowsiness and headache. Some of these are underreported because if you have nausea and vomiting and fever 3 days after the exam, then the patient and the clinician may not make that connection that it might be related to that IV dye that they had several days prior. Most of these delayed reactions may occur 30 to 60 minutes to 1 week later, but more commonly, 3 hours, between 3 hours and 2 days later. So what do we do when we get that phone call? What is it that we're actually going to do? Well, we have to know where to go. We're going to walk fast or run, better yet, towards that room because they might be having severe contrast reaction. We're going to just assess the patient and see how they look. If you walk into the room and they're pale, they're clutching their throat, they're not able to speak to you, then I'm thinking, I need help right now. I'm going to pull out my Epipen, first of all, and I'm going to call my emergency response system because I think this patient is having a severe allergic type reaction. Even before the nurse tells me vitals, even before we hook them up to monitors, when you look at them and you understand the patient is not able to talk to you, they're scared, if they're having laryngeal edema, or if they're flat out non-responsive by that time, then first of all, I feel like I need help. I need to call my emergency response system. I want people to come and help me follow my BLS or ACLS protocol and do the resuscitation protocol. And the most important thing that I can do as a radiologist is quickly administer epinephrine or adrenaline. So those are my two first actions when I recognize that there's a severe reaction. I will call for help or ask a nurse to call for help, and I will get the emergency box. So each room, each scanner is equipped in our hospital with a special box where we have emergency medications such as epinephrine and adrenaline. Okay. But other things that we need to do, and hopefully we have help. You can't do it all on your own as a radiologist. I can't. There has to be a nurse and a technologist usually, or maybe a resident if you're lucky. So you need people to help you do all this. Maybe a nurse can secure the intravenous access. They can help us monitor vital signs. We need pulse oximeter. We need to tell the nurse to put oxygen by mask, 6 to 10 liters per minute by mask. If we have IV fluids, then we can tell the nurse again to give IV fluids. We may need to elevate the legs. So in the contrast reaction kit, we have several medications, the most important of which is the brand name is Epipen, but there are other epinephrine or adrenaline autoinjectors. The American College of Radiology recommends certain things in the area where the patient is scanned, such as having a stethoscope, blood pressure, pulse monitor, pulse oximeter, oxygen, defibrillator, or AED. And the most important medications that we must have where the patient is being administered contrast is epinephrine, IM or intramuscular, or autoinjector, albuterol inhaler or nebulizer, and an antihistamine, such as diphenhydramine or Benadryl. There are other medications that we keep in our box, but at least we must have epinephrine, albuterol, and antihistamine. ACR also suggests some discretionary or optional medications, so such as atropine for our vasovagal reactions, some steroids, nitroglycerin, aspirin, Lasix, blood pressure medications, having dextrose or some sort of glucose for our hypoglycemic patients. This is what our own pre-medication, not pre-medication, but emergency kit looks like, and we keep it in each area where the patient is being scanned. So this is for an adult patient, 30 kilograms or greater. Here is our phone number to get the help for the emergency response team or a code team. And this is what we have inside. So there are two EpiPens, our auto injectors, and then we have Benadryl and we have glucose packets and some steroids and syringes. But the most important things will be the Benadryl and the EpiPen. So just briefly about antihistamine or diphenhydramine or Benadryl is the brand name. It has antihistamine, anticholinergic, and sedative properties. The usual dosage is 25 to 50 milligrams, and you can give it either orally or intramuscularly or intravenously. If we're going to give it IV, we must administer it very slowly, over 1 to 2 minutes. Possible side effects are drowsiness. If we're giving it intramuscularly or intravenously, it may cause worsening. It may cause hypotension or worsening of hypotension. It can also cause thickening of bronchial secretions. If we're giving Benadryl, either orally or IV, whichever way, we usually watch the patient at the nursing station for up to an hour because that might make them drowsy and they may not be able to drive on their own. Now, if they have a driver, if somebody came with them, then we will watch them maybe for 30 minutes or so. If they're doing well, we will release them with somebody else, with a family member or friend, to take them home. If they're by themselves and they are the drivers, then we'll watch them for about an hour at the nursing station. And then one of the residents or staffs goes in, looks at them, reassesses them, make sure they're alert enough to be able to drive. And epinephrine or adrenaline, as it's commonly known in other countries, it acts on alpha and beta receptors of sympathetic system. It relaxes smooth muscle of bronchi. It's physiologic antagonist of histamine, increases blood flow and cardiac output. So these are those doses. So in the past, when I was a resident, we didn't have the auto injectors available. So each time you have a contrast reaction, we would have to remember all of these dosing and the dilution of each intravenous versus intramuscular dose. And it was not an easy task to do. Literature says that a lot of us radiologists or medical professionals do not remember correctly the dosing of epinephrine. And there were many cases, unfortunately, where intramuscular dose and that dilution was injected IV and vice versa. Okay, but these are the doses if we're going to do IV or IM. The best way, in my opinion, and that's what our practice has been doing for several years, each site carries an auto-injector, an EpiPen, and that's a fixed dilution. You don't have to remember the dose, the milliliters, the milligrams, because that's a hard thing to do, to remember all of these dosing and tell the nurse to administer the correct dose. With an EpiPen, all you need to do is, one, that you need to get it right away, and two, how to administer it correctly and try not to inject your own thumb. Inject patient's thigh rather than your own thumb. So there's a blue and an orange side to the EpiPen, and I will show you. So there are lots of auto injectors on the market, and you will have to know, if you have it available, which one you carry and how to use it. You can YouTube a video. I have my residents YouTube a video how to use an EpiPen, but this is what ours looks like. There's a blue part and an orange part. So we say blue to the sky, meaning up, and orange to the thigh. So we would flip this blue part up and swing it and then inject it into the upper outer thigh. And then we hold it for about 5 to 10 seconds there. And that's the action. That's how epinephrine or adrenaline will be injected, hopefully intramuscularly. Now we understand that sometimes the patient is large, especially in our country, in the United States. Obesity is a big issue. A lot of our patients are larger and they will have subcutaneous fatty tissue. The idea is to inject the muscle. So if I see that the patient is very large or obese, and I know that with my needle, which is fairly small, that I may not get to the muscle, then sometimes we have to inject the arm. And in the arm, there's a better chance of having less of a fatty tissue and getting close to the muscle. And this is what EpiPen looks like. And their instructions listed. So it says swing and firmly push orange tip against outer thigh, So it clicks. So it clicks. You can use it through the clothing, even if they're wearing pants or jeans. It's okay to go right through the clothing and hold on thigh. Some people say 3 seconds, other people say 5 seconds, but 5 to 10 seconds, I think, is a good way to hold there. Okay, and again, I teach my residents blue to the sky and orange to the thigh so that they don't invert it and they don't inject their own thumb inadvertently. So I'm a strong believer in getting help. So once you recognize that you're in that type of situation, you might need help. I encourage you all to know your own emergency response team's number and how to get a hold of them, whether it's your local hospital system. We have a rapid response team that consists of anesthesiologists and respiratory therapists who will come. They have a pager and they will come to that area that needs help. If it's an outpatient clinic, then we just call our external emergency service or 911 in our country. In Europe or other countries, it might be a different number, such as 112, or you would know your own way of getting help. So let's talk about the actual reactions. So they're mild, moderate, and severe reactions. Mild are self-limited signs and symptoms without progression. So they're allergic-like versus physiologic. So if the patient is having any of these symptoms, we would not code them, so to speak. We would not categorize them as having allergic reaction. They can still have a CAT scan next time. It just means that their body is now reacting, and we expect their body to react in this way. Versus if they're having these symptoms, we will put in their chart that they are allergic to contrast, and next time they need a CAT scan, they need to be pre-medicated. Okay, so physiologic reactions, mild or limited nausea and vomiting, transient flushing, warmth, chills, headache, dizziness, mild hypertension, vasovagal reaction that resolves, versus allergic-like reactions or limited urticaria, pruritus, cutaneous edema, limited itchy or scratchy throat, which is quite common in my opinion, nasal congestion, sneezing, conjunctivitis, and rhinorrhea. This is what hives might look like. When I'm assessing the patient, I will look at their skin. I will expose their chest and back. Usually they will be on the neck and chest and back, but I will look at their arms and legs and abdomen and nearly the entire body, because they may not realize that they're having a reaction, but we need to see their entire body. And again, for these mild reactions, if they're doing okay, they're not scratching or it's not painful for them, then we can just observe them. We don't have to give them any medications. If it's painful or very itchy for them, then Benadryl is what we would use, either oral or IV. I usually give it oral for hives, or you can also use a newer agent, fexofenadine or Allegra. Okay. So moderate reactions, again, physiologic versus allergic-like. For physiologic, now we have more or protracted nausea and vomiting, hypertensive emergency, some chest pain, vasovagal reaction that requires and is responsive to treatment. Allergic-like reactions, diffuse. So instead of limited, now we have diffuse urticaria and pruritus, diffuse erythema. So their entire body or a large portion of the body is involved by this process. Facial edema without dyspnea, throat tightness, hoarseness, wheezing, bronchospasm, mild or no hypoxia. So diffuse erythema, again, the manual goes over each one of these situations, so we may not be able to cover it all, but let's say for diffuse erythema, if they're normotensive, we may just watch them. If they're hypotensive, we will give IV fluids. And if we're ready, if they're getting worse, then again, our wonder drug is epinephrine or adrenaline. We're going to give it in whichever way, IV, IM, or with an auto injector if we feel that the patient is deteriorating and progressing to a more severe like allergic reaction. For bronchospasms, we carry albuterol, beta agonist inhaler. So if we feel like that's their type of moderate allergic reaction, then we give 2 puffs of albuterol, and then you can repeat it up to 3 times as needed. And if they're getting very short of breath, then again, we're going to get ready for epinephrine injection. With vasovagal reactions, in my own personal experience, it's not that common, but I've seen it. I see it more in breast imaging when we do our biopsies and breast procedures. But vasovagal reaction is hypotension with bradycardia, with heart rate less than 60. Patient might be pale, sweating, diaphoretic with decreased level of consciousness. We will need to elevate the legs greater than 60 degrees, give them oxygen if we need to give IV fluids, and consider atropine. I've never had to give an atropine, but it's on our emergency box and we could give it. Okay, so for vasovagal reaction, again, here's the dose of atropine, 0.6 to 1 milligram administered into running IV infusion of fluids, can repeat up to 3 milligrams total. And now up to the severe reactions or life-threatening reactions. So now we're dealing with diffuse edema or angioedema with dyspnea, diffuse erythema with hypotension, laryngeal edema with stridor and or hypoxia, wheezing, bronchospasm with significant hypoxia, anaphylactic shock, and unfortunately death. In my own opinion, the most severe reactions that I've seen were with laryngeal edema. Those are the ones that I personally have to administer epinephrine for. So for laryngeal edema, again, as soon as you recognize that you walk to the room, they're usually not able, there's no airway for them to tell you. They're scared. If they're awake enough to even, show you that they can't breathe, they usually will be clutching their throat. And there's this very abnormal sound, usually that inspiratory stridor that you might hear. So you just have to recognize that that's what's going on. And epinephrine is what we will use right away. And luckily, in my own experience, as soon as you give it, as soon as you inject that epinephrine, they're literally taking a breath and a big breath in. And what happened, doctor? Thank you for helping me. I couldn't breathe, and now I can breathe. It works well and it works fast. Usually, it's a good drug to use. Now, the patient will still be transferred to the emergency room, even if they're doing well or better. I will still transfer them to the ER to monitor them. If they just had a severe reaction and I resuscitated them and they're doing well, they're still going to the ER because I need them to be monitored, for at least some time, make sure they're doing okay. If the patient is in pulmonary edema, then we might need to give diuretics or furosemide or Lasix. Okay, we carry stethoscopes, so if you know how to evaluate for pulmonary edema, some of us radiologists may or may not remember how to do it correctly, how to listen to the lungs and understand that the patient is having pulmonary edema, but we can watch for tachypnea, tachycardia, diaphoresis, rails, blood tinged sputum, then we can give Lasix as needed. Usually by that time, again, I'm already transferring the patient to the emergency room where there are other physicians who are trained better than me, perhaps, to administer those medications. And if it's severe pulmonary edema, again, our backup medication is epinephrine. So for pediatric contrast reactions, again, similar protocol, the medications will be based on the weight of the patient. We want to fully expose the skin of the child because they may not be able to say if they're itchy or scratchy or hurting. So we need to look at their entire body. And with contrast extravasations, rarely do they happen, but they do happen. So we inject the IV and the patient might complain of swelling and tightness in their arms. So we usually, one of us radiologists or resident goes in to evaluate for pain and swelling and edema. We need to remember that the inflammatory response may peak at 24 to 48 hours. Okay? So things to watch for is compartment syndrome. If we injected a large bolus or 100 cc bolus of contrast into their arm, then we need to make sure that they have normal sensation and capillary refill in their fingers, that they can do, you can do a quick neurological exam. And then if they're still doing okay, then usually we elevate the extremity at or above the heart level. We can apply either cold or warm or hot towel around the arm. It just depends on the clinician's preference if you apply cold or hot. Reassure the patient that it will go away. And then we only reserve the surgery consult if there's skin ulceration or necrosis or blistering or compartment syndrome, if there's altered perfusion or abnormal neurological exam. And this is what contrast extravasation might look like: a red swollen arm and decubital fossa. This patient had a CT apparently, and it just showed up in his arm, even on the scout image for the CT. These are some of the other images showing as contrast extravasation. So briefly about post-contrast acute kidney injury and contrast-induced nephropathy. So these are difficult topics. The literature is not as conclusive, or radiology literature. Some radiologists believe that that's a real entity, while others think that it may or may not be a real event, but it's basically worsening of the renal function, hopefully temporary worsening of the renal function following administration of IV contrast. There are certain risk factors. Certain patients are at higher risk of having contrast-induced nephropathy. Here you can see a list such as diabetes, dehydration, pre-existing renal insufficiency being the main one. So again, we would check renal function, not in everybody, but there are certain groups of patients where we would check their GFR and creatinine, such as patients with prior renal insufficiency, patients on dialysis with kidney transplant, single kidney, kidney cancer, hypertension, diabetes. We would check their renal function prior to administration of contrast. There is no agreed upon threshold of serum creatinine or GFR, so it really depends on each one of us radiologists. So technologist or nurse will call us in the body reading room and say, this patient needs a contrast and their GFR is 25 today, so it's low. What would you like for me to do? Would you like to give it or not give it? And then I decide whether I feel it's safe to give or not. If I'm not sure, I will call the clinical doctor and talk to them about this particular patient. In general, if their GFR is less than 30, then we might need to speak to a clinical team. If their GFR is greater than 30, then a lot of times we will go ahead and give full dose of contrast. Okay. Now, the best thing that we can do and advise clinicians to do to prevent contrast-induced nephropathy is hydration, either oral or IV. IV is easier and more robust. So isotonic fluids such as lactated Rainier solution or normal saline. We do not prescribe sodium bicarbonate or N-acetylcysteine or diuretics. Other clinical teams such as nephrologists and cardiologists sometimes use those medications trying to prevent contrast-induced nephropathy. It's never been proven in radiology literature that they may be helpful, so we do not prescribe. The only thing that I will advise clinicians to do is hydration before and after the exam. Moving on to gadolinium based MRI contrast agents, again, commonly used in practice. Fairly safe agents. They're not as commonly having allergic-like reactions, rare adverse events. Risk factors for adverse effects with gadolinium or iodine allergy, prior reactions, asthma. Treatment is identical to iodinated contrast reactions. Again, there are different agents on the market. The one that we use at our hospital is multi-hands, EUVist and Gadovist. We carry these three agents, but there are other agents out there on the market, and you just have to be familiar with your own agent at your institution. So just briefly touch base on nephrogenic systemic fibrosis. It's been known for a while about this entity, but it's been associated with gadolinium since about 2006. It's a process where the patient might have thickening and induration of the skin and other organs such as lungs, esophagus, heart muscle. It's may be associated, or it's been found to be associated with gadolinium administration. Usually it's cutaneous abnormality, but because it can involve the internal organs, there's no good treatment from what I know, and sometimes some patients will die from this condition. Exact mechanisms are unknown. There are all sorts of theories on how it works, but I don't think that we know for sure how it happens and why it happens. So there are risk factors. Certain patients are at higher risk for NSF, or nephrogenic systemic fibrosis. such as chronic kidney disease, patients who've had NSF, they had severe or profound renal insufficiency, in chronic renal failure, and or patients on dialysis. But there are other risk factors, such as acute kidney injury, high doses and multiple exposures to gadolinium, hepatic insufficiency, hepatorenal syndrome. So if the patient is on dialysis and they need to give gadolinium, we will arrange hemodialysis as closely to the exam as possible, typically the same day. It's our radiology policy to have dialysis the same day of the exam. Okay, they can still have gadolinium, they just need to have that hemodialysis. With peritoneal dialysis, it may provide less NSF risk reduction compared to hemodialysis, but has not been adequately studied. So it's a base, kind of case-by-case scenario. If the patient is peritoneal dialysis, then we will have to assess if they really must have gadolinium, and the radiologist must approve that administration. So there are different types of gadolinium agents. They're categorized as group 1, group 2, and 3. In general, group 2 agents are believed to be safer for nephrogenic systemic fibrosis than group 1 and group 3. So the one that we use at our hospital is multihans and Gadolinium, so they're group 2. So the new ACR manual says that they're believed to be very safe now, that we don't have to even check their renal function, and we don't have to consent. So consent and checking renal function is now optional in the new ACR manual if we're about to administer group 2 agents. Now, if they're getting group 1 or group 3 agents, and EOVIST is group 3, we still have to check their renal function and we have to consent for NSF. So my department is in the process of changing our own policy, where we will most likely not be checking their GFR and creatinine anymore, and we will not be consenting for NSF anymore. As of now, we still do those things, but we are about to revisit and look at all of it again. We're going to skip some of this. So with group 2 agents, very low, if any, risk for NSF, regardless of renal function or dialysis status. There are preferred agents in patients at risk for NSF, and as I said, optional labs and optional consent. Just one slide about gadolinium deposition in the brain. So I think most of us have heard about it by now. It's kind of a newer entity. When I was a resident, we didn't know that gadolinium deposition happens in the brain, but now we do know that it does deposit in the brain. Pathologically, our pathologists can see it. Luckily, to date, no adverse health effects have been uncovered. So no histologic changes to suggest neurotoxicity. So we know that it's there in some patients, but luckily it doesn't cause any neurological deficits as far as we know. It may be dose dependent and can occur in patients with no clinical evidence of kidney or liver disease. We pay particular attention to pediatric patients receiving gadolinium agents and those with multiple repeated doses of gadolinium. And further research will show whether or not it's a significant issue, and whether or not we will see some neurological defects developing in the future. Hopefully we will not. Pregnancy and breastfeeding, and there are no special precautions for CT contrast, so pregnant patients can have IV contrast, and breastfeeding patients can have both can have IV dye. Gadolinium is contraindicated in pregnancy, so if we need to scan a pregnant woman for right low quadrant pain, perhaps, or fetal MRI, we will not give gadolinium. Breastfeeding is safe after both iodinated and gadolinium contrast administration. Mothers can be given an option of abstaining or pumping and dumping breast milk for 12 to 24 hours, as trace amounts of iodine and gadolinium may be secreted. But if they choose not to do that, we feel it's safe for breastfeeding patient having contrast to keep breastfeeding. And this is my last slide. So what am I trying to say with my lecture? So what we do at our institution to help us all prepare for these allergic reactions, we do annual lecture and mock contrast reaction demonstrations for our residents, fellow, and staff. Okay, so that each year, at least once a year, we remind ourselves on how to do it, how to use Epipen and the doses of our emergency medicines. Most of us, or a lot of us, carry reminder cards, again, from the ACR website in our pockets. You can take a picture, have it in your phone. We have emergency kits in each scanning area containing some of those emergency medications. With our nurses and technologists, we do mock contrast reaction demonstrations. Actually, unfortunately, after one that didn't go well that I was involved in, we requested that we do these mock trials. So we pretend as if the patient is having contrast reaction, and then we as a team resuscitate with the nurse and the technologist. And my own personal advice is call for help sooner than later if you're in that situation, so you have other people helping you in the radiology. And be brave, prepared, and stay warm. And that is the end of my talk. I'll be happy to take any questions. I appreciate your attention and listening to my talk today.
Thank you very much, Dr. Muinov, for this great presentation. It was very complete. So now I will start with the questions. We have now, so first question from Dr. Espinoza. So he would like to know if a pregnant patient with history of severe allergy can receive a pre-medication and iodinated contrast medium.
So pregnant patient with severe allergy can receive pre-medication. So yes, the pregnant patient will usually receive the same type of pre-medication as anybody else. We for sure involve the clinical doctor in that decision. I would not give it to a pregnant patient just on my own. I would not prescribe it, but I would call the clinical doctor and talk to them if they really must have, if they have a problem that requires IV contrast. I'm assuming that they're having something very critical going on, such as rule out PE, rule out trauma perhaps, or maybe it's a cancer patient, unfortunate cancer patient, then yes, we will give them the same steroids and Benadryl pre-medication as anybody else with approval from their clinical physician or OBGYN team.
Thank you. So second question now, can iodinated contrast medium be administered through a central venous pressure catheter?
Good question. Central venous pressure catheter. You know, I have to admit, I'm not expert on different types of venous catheters, but yes, from what I understand that question, that it can be given through a central catheter. We do commonly use central catheters to do contrast. Usually it's a peripheral IV in their arm, sometimes in their leg, sometimes everywhere. I've seen intraosseous injections also, but yes, we can use a central catheter as well. Usually our nurses and technologists are trained better, so I have to admit I'm not an expert on that.
Is there any recommendation for patients on ongoing blood transfusion who has to undergo IV contrast CT? Should a CT or blood transfusion be withheld, since we will not be able to reliably distinguish the cause of anaphylaxis if it occurs, if it came from the blood product or due to the IV contrast? Or do you recommend pre-medication prior to CT as well? Thank you very much.
So for ongoing blood transfusions. Right, so again, it's not that common that this question would arise, but I see it's a good question to think about. Again, it's a case-by-case scenario, and if that patient needs an exam for something that's very acute, then we will take our chance and we will go ahead and give contrast. So we would rarely stop contrast administration because they have, but I see your point. How would we ever know? And if they're going to have some sort of reactions, then we will still have to resuscitate them in the same way, you know, that we know to resuscitate with the epinephrine. So if they must have IV contrast, if they have an indication that requires, you know, if they're bleeding, then we will take that chance and we will give IV contrast and kind of see what happens. But the clinical team, again, we discuss it with the clinical team, we would document with the clinical team, but yes, we would give IV contrast to that type of patient and take our chance if we feel that that is the only way to image them, if the indication is emergent enough for us to give contrast.
Next question. Thank you for the presentation. I want to ask which is ideal, giving medication like hydrocortisone prior to investigation or after, or is it dependent on department protocol? I'm asking because I saw from your slide that emergency medication is given 4 to 5 hours prior to investigation.
So as a pre-medication protocol, we would always give it before. It's always given before. So our usual pre-medication prep is oral prednisone and Benadryl, 13 hours, 7 hour, and 1 hour before the exam. That's our outpatients. If it's an emergency room patient and we don't have those 13 hours to wait, then we would give IV steroids, and we would ask for 4 to 5 hours, but we understand that we may not get it. That emergency room doctor will most likely tell me that they must do the scan right away. So we will still say, yes, go ahead and give the IV dose. It may or may not help. IV steroids have not been shown to be, helpful if administered 4 to 5 hours. But I think in our practice, most of us will still say having IV steroids in the system may be protective and it may help. So I personally go ahead and tell them to do it. So they give the IV steroids and then just go ahead and scan the patients, understanding that it may or may not help, but at least I feel I'm trying to help them prevent that contrast reaction.
How many contrast reactions do you have per year in your radiology department?
Yeah, I don't know if I have the exact number, but as I said, so we have about 10 radiologists, body radiologists in our practice, and from talking to them, maybe each one of us will have about 1 severe reaction a year. So I would say maybe in general, I would guess maybe 5 to 10 severe contrast reactions a year. I could be wrong. I personally feel like I attend about once a year that's severe, where I have to give epinephrine and transfer to the ER or call 911. But as far as mild reactions, I would say maybe a couple a week that one of our residents goes and evaluates for a rash or hives or sneezing or itching.
In addition to GFR, should we also measure albumin creatinine ratio in patients with diabetes or hypertension prior to contrast administration?
So when we check our renal function, those patients who are at risk, and we have a policy stating which patient needs to be checked, then we do a full panel. So we do what we call BMC panel. So that will include GFR, creatinine, and albumin creatinine ratio. I think it's a part of that panel, but we always get at least GFR and creatinine for patients with, patients with diabetes, with renal insufficiency. If they have any sort of renal issues, if they're greater than 60 years of age, then they will get a full panel, including GFR and creatinine.
Hi, this is Bill Dillon for Health for the World, and unfortunately our time has come to an end, but I wanted to thank you very much, Dr. Muinov, for what I think is a very important lecture for all of us.
Thank you.
And my takeaway is that we have to practice these emergency situations because they don't come up very often, and when they do, there is a lot of anxiety around them. So getting prepared is really a message that I take away from your wonderful lecture today. So thank you so much. Appreciate it.
Thank you for having me. I appreciate your time and giving me a chance to speak.
Beautiful, beautiful. It was a wonderful lecture. Thank you so much, and thank you to everyone who's listened today. And we hope that you're all safe. And if you're in Texas, warm, or at least getting warmer, and around the world, please be safe. Okay, thank you so much.
Thank you. All right, goodbye.
Bye-bye.
Thank you for your help. I appreciate it.